Hello friends and welcome back to Gastro Guru. My name is Dr. Nisarg Patel. I am a gastroenterologist from SIDS Hospital, Surat, Gujarat. Today we'll discuss how to test and treat a patient with vomiting in an emergency department or in your OPDs. So these videos will help both the practicing doctors as well as the medical students to understand the gastroenterology as a subject better. Also, this might help you in your exams as well. So kindly watch these videos. For any suggestions, kindly post me in the comment section.
गैस्ट्रो गुरु के साथ बढ़ाएं अपने पाचन स्वास्थ्य का अनुभव, जहां विज्ञान और वास्तविक ज्ञान मिलते हैं। ऑथेंटिक मेडिकल हेल्थ इंफॉर्मेशन, गैस्ट्रो गुरु के संग।
So beginning with the talk, so in the last two parts, the part 1 and part 2, what we have seen is that there are 5 major causes of vomiting. It can be gastrointestinal, it can be extra gastrointestinal. So for extra gastrointestinal, it can be either drug related causes, it can be metabolic causes, it can be CNS related causes, it can be ENT, and there are some special causes like functional vomiting, eating disorders, chronic nausea vomiting syndrome, CVS, that is cyclical vomiting syndrome, cannabis and migraine. So these are the causes. Kindly refer back to video number 1 for the same. The key points in history, we need to differentiate between acute and chronic, acute and episodic, chronic and episodic. So these are the 3 kinds of origin, duration, progression that we see. We need to be very sure by asking the patients the right questions. And by asking the history in detail, we can narrow down the causes of history. There are different types of vomitings, mainly 6 types. It can be early vomiting, early morning vomiting, retention type, immediate post meals vomiting, projectile vomiting, bilious vomiting, and feculent vomiting. We can differentiate the causes in a similar manner. Refer back to video number 1 and 2. So now when a patient of vomiting comes in your emergency department, you need to be very sure whether the patient requires urgent care or the reason is non-urgent. So for urgent care, always check for if the patient is having bilious vomiting, if there is some neurological deficits, or if the patient is becoming acutely ill, so that the patient is developing tachycardia, hypotension, the urine output is less, the patient is seeming to be dehydration, in very much agony. It means the patient will require urgent care. I have listed some of the common causes that we come across usually. It can be intestinal obstruction, it can be hollow viscous perforation, it can be some infectious process like acute gastroenteritis, acute pancreatitis, acute appendicitis, any organ infection, even myocardial infarction can cause nausea and vomiting. Any central cause, Addisonian crisis and decay, these are the metabolic causes, or if the patient is having some sort of poisoning. So these are the common causes in which urgent care is required, and we need to investigate these patients faster. So how to test these patients? So obtain a good medical history, as discussed in part 1 and 2 of the videos. We do a basic blood test. So basic blood tests are CBC, CRP, renal function test, liver function test, metabolic profile for calcium, thyroid, sugar, acetone, for pancreatitis, amylase and lipase, for urine routine to rule out any UTI or pyelonephritis, and a acid blood gas. So these are not very exhaustive. Always decide which test to do based on the history. So just to give you a common sense, so if the WBC is high, CRP is high, then we are dealing with some sort of infection or inflammation anywhere. If the electrolytes are going up and down, so if there is hypo or hypernatremia, it can be the cause or effect of the vomiting, either ways. For metabolic acidosis with high lactate, we are dealing with a patient of mesenteric ischemia or infarction or sepsis somewhere with shock. When the liver function is deranged, always think of acute hepatitis, acute cholecystitis, acute pancreatitis, because these are interlinked. Also, drug related causes of drug induced liver injury can be the cause of vomiting. Hypo or hypercalcemia, again cause or effect of vomiting. For decay and starvation ketosis, we can get a very good idea based on the EBG, RBS and acetone levels. For acute pancreatitis, amylase and lipase. So these are tests. These blood tests are not very exhaustive. We can do it on case to case basis. So then start the supportive management. So we need to correct dehydration, hypotension, electrolyte imbalance as the investigation continues. If the patient is female, always ask for the menstrual history, and if required, do UPT or beta HCG to rule out any pregnancy, either normal or ectopic pregnancy. When there is a GI obstruction suspected, so if there is a colicky pain in the abdomen with bilious type of vomiting and tenderness around the periumbilical region with distension, so then we might be dealing with a case of intestinal obstruction. For such cases, do a plain X-ray straight away. If the care is immediately available, then get an ultrasound or a CT scan done. Mind you that hydration is very important before doing the CT scan in such cases, because if the patient will be dehydrated, then the patient might land in contrast-induced nephropathy. Also, try to avoid giving Dynapar or diclofenac in such cases. First, be sure that what are we dealing with, and then only give any such drugs. So if there is no GI obstruction suspected, then ask for that whether there is a recent surgery, radiation or chemotherapy, in which we can define the causes. Rule out any GI or systemic infection. Mind you, any infection anywhere in the body can cause nausea and vomiting. Even otitis media can cause vomiting. Even a dental caries can cause vomiting. Even pneumonia, UTI, PID, pelvic inflammatory disease, any kind of infection can cause vomiting. Always inquire drug and toxin history in detail. So common drugs which can be responsible for vomiting are antibiotics, painkillers, multivitamins. Any recent changes in the current drugs. So if the patient is already diabetic, antihypertensive since very long, so always ask कि last 3 महीनों में कोई दवाई आपका change हुआ है कि नहीं. Any drug which causes electrolyte disturbances like diuretics. So for such cases, always be very careful. If the patient is on Ditop Plus, always check for the sodium levels. Always check for the creatinine levels. There are many drugs which can cause hypomagnesemia. So, so now there are, if there are any neurological or vestibular reasons like headache, giddiness, if there is earache, ear discharge, if there is vertigo, and always think of either CNS or ENT causes. And in such cases, if required, do a MRI or a CT brain. And obviously, electrolyte imbalances we have discussed in detail. So this is how we can test the patients of vomiting. Obviously, it starts with a good medical history. So now, what is the role of endoscopy for patients of vomiting? So indications of endoscopy at first. When to do this endoscopy? For acute symptoms, if there are alarm symptoms like GI bleed or weight loss, then yes, immediately endoscopy has to be done after adequate resuscitation. For all chronic and episodic patients, if we are not able to find a particular cause, then yes, endoscopy is required for all the patients, just to rule out that we are not missing on to something. So for endoscopy, what do we actually find? So in eclasia, we find usually eclasia cardia, or it can be a tumor in the esophagus. At GE junction, we can find hiatal hernia. In the stomach, we can find gastritis, gastric ulcer, malignancy. For duodenum, again ulcer, it can be a groove pancreatitis. So when there is a recurrent acute episodes of pancreatitis or a chronic pancreatitis, the head of the pancreas, if it is getting inflamed again and again, it will compress the duodenum and it will cause a groove pancreatitis. So there will be pancreatitis in the duodenal groove, and it will cause narrowing of the duodenum, and it will cause gastric outlet obstruction. SMA syndrome, that is superior mesenteric artery syndrome. So when the superior mesenteric artery is traversing through the third part of the duodenum, because of any reason, if the angle is getting narrowed, so it will compress the duodenum like this, and it will result in an SMA syndrome. It is not very common, but we do see such cases. Mind you that gastroparesis is one thing which is a functional problem. So there will be endoscopy is usually normal in cases of gastroparesis. In some cases, we can find retained food after 6 or 8 hours of fasting. But gastric emptying test is the good test to pick up gastroparesis. So endoscopy, basically you need to, we can see the esophagus, the GE junction, the stomach and the duodenum, and these are the different causes of vomiting that we often find. Now coming on to the drugs, just a quick recap. So there are H1 receptors, there are M1 receptors, which are central receptors. They are responsible for pregnancy related vomiting as well as some hormonal problem causing vomiting. There are central and peripheral serotonergic, that is 5-HT3 receptors, which increases dopamine. So there are drugs which are acting on these receptors. There are NK1 receptors, so there are drug acting on these receptors. Always remember that there are different pathways for nausea and vomiting. So there will be many patients who will have only nausea without vomiting, and there will be patients in which there will be vomiting without nausea. So keeping in mind these receptors, we will now move to which drugs to use and when to use. So drugs are like domperidone. So domperidone usually acts in a peripheral D2 or area postrema. The common indications are dyspepsia, any GI infection, or Parkinsonism. It will cause increase in prolactin. It can prolong QT intervals. So practical point in using domperidone, that we are using combinations. So for example, Arbison D. So it will contain 30 milligram of domperidone. Many of the physicians or residents I have seen that they are giving on a BD dose. So 60 milligram domperidone can cause prolonged QT interval and can be harmful to the patients. So any fixed dose preparation which is containing domperidone for 30 milligrams, try to use it only once a day. So if you are requiring a BD dose of PPI, then use the fixed dose in the morning and a plain PPI. For example, Arbison D in the morning and plain Arbison in the night, or Razo D in the morning and the plain Razo in the night. It is important that in the patients who are of Parkinsonism, when they are started on levodopa, many of the patients, almost 30% of the patient, will complain of nausea and vomiting. So for Parkinsonism patient, we cannot use metoclopramide, levosulfide, and even some cases of etopride. Etopride usually doesn't causes the blood-brain barrier, but it is always safe to use domperidone. So because there will be increase in the dopamine levels, it will cause nausea, and domperidone is a wonderful drug to prevent, because it acts on the peripheral D2 receptors. It will not cross the blood-brain barrier. The second group of drugs are prokinetics, that is perinom, metoclopramide, and levosulfide. They act as a central receptor, so they are central D2 antagonists. Plus, they have a motility action on the enteroduodenal area. There is a common misconception that in the cases of diarrhea we must avoid perinom, but perinom has no effect on the colonic movement. It only propels the enteroduodenum area, so it is a prokinetic, but it has no action on the colon. So for diarrhea patients, we can use metoclopramide safely. When it is used, so any post-op cases, maybe a GI or non-GI surgery, it can be used for post-chemo or radiotherapy cases. It is safe in pregnancy. It is tried and tested in pregnancy. It is class B, class C. For diabetic gastroparesis, again, it is a wonderful drug. But the problem is, if we are using it for the long time, then it will cause tachyphylaxis. Also, 1% of the treated patients might have distressing extrapyramidal side effects. We must avoid both of these drugs in Parkinsonism. So, we have seen many residents and doctors which are afraid of using metoclopramide because of the EPS. But statistics says that only 1% of the patients develop EPS, and they are usually quite well manageable. Then there are centrally other acting drugs like chlorpromazine, available with a brand name of Larjactil, Cpzod, or Emetil. Larjactil nowadays is not very well available. I use Emetil if it is required. Prochlorperazine, that is Temetil, 5 mg. Promethazine, that is Evomin, and Finargan, that is 25 mg. So Finargan is a wonderful drug if the patient is developing EPS from perinom or metoclopramide. We can give an IM Finargan. It acts on 3 receptors, that is dopamine receptors, M1 receptors, and H1 receptors. The common side effects that we see are drowsiness, and again in some cases there can be extrapyramidal side effects. It is used in the cases of vertigo, motion sickness, or migraine headaches. So it is centrally acting drug because it acts on the M1 H1 receptor. So the green dots that we have seen in the previous slide, so M1 H1 receptors are usually centrally located, and dopaminergic receptors and serotonergic receptors are both central as well as peripheral. So now a quiz question. So domperidone, we all know that it is a peripherally acting drug. So how does it increase prolactin? This question has been asked many a times in the MCQs as well. So the answer to this question is that the dopamine, when it is released, it inhibits the prolactin levels. But domperidone, as we see, it doesn't cause the blood-brain barrier. So, but it acts on area postrema. So area postrema is in the brainstem. half of the area prostrema is outside the blood-brain barrier. So dopamine can act on area prostrema, the lower part, which is outside the blood-brain barrier. Also, dopamine, the domperidone reduces the circulating levels of dopamine. So because of this mechanism, it will cause high prolactin levels. So other drugs, dexamethasone, yes, many of you will be surprised that dexamethasone as an antiemetic, but it is written in the textbook Harrison as well as Selzinger as well. The mechanism of action is that it inhibits the central prostaglandin synthesis, and it releases endorphins. So it is a very good drug for status migrainous, for cerebral edema, for any refractory vomiting. But the catch is that it must be always used in combination. So you can use dexamethasone with pantoprazole with MSET. So this combination for any refractory vomiting, if you are not able to find out any cause, but just give one stat dose of around 8 milligram, not more than that. So it is used as a temporizing method until and unless we are able to find out the cause. It must not be used regularly. Then obviously the famous drugs, that is 5-HT3 receptors antagonists, andonsetron and granisetron, they are available in India. The use is general, we can use for any of the causes. The main side effects that I want to highlight is constipation. So we must avoid in any patients of intestinal obstruction or pancreatitis, because this will decrease the intestinal motility. For pancreatitis and intestinal obstruction, what we require are prokinetic agents. So this is one particular case in which I would always recommend to use metoclopramide over ondansetron. Other drugs are doxylamine succinate. It is a famous drug for pregnancy. Always mind you that we must always give it with pyridoxine. It comes in combination. Pregnancy, it acts on H1 receptor. So they are again centrally located. Because they are antihistaminic, it will cause drowsiness. It has anticholinergic side effects like diplopia, urinary retention, and dry mouth. The important thing is the vomiting in the pregnancy is early in the morning. So we must use the drug at night. So this is the common mistake that many of us do, that we give doxylamine in the morning, but the dose is 20 milligram in the night, 20 to 30 milligram in the night, and then if required we can use it in the morning and afternoon as well. But most of the cases of hyperemesis gravidarum, if you are using doxylamine 30 milligram at night after dinner, usually it works very well, and we need to maintain hydration and ask the patient of hyperemesis to take small frequent meals. Then stugeron plus stugeron, that is cinnarizine with diamine hydronate combination, cyclizine, meclizine, hydroxine. So atarax, we all know that we use it for itching, but yes, it is very useful in decreasing vomiting as well. So in the patients of acute viral hepatitis with cholestatic phase, if the patient is having itching and you require antiemetic as well, then atarax will work for both. Basically, these drugs act on muscarinic receptors, M1 receptors, and they are usually useful for the motion sickness. Also, mind you that we need to give these drugs almost 1 hour to 30 minutes before sitting in the car. So, and always ask the patient that they will have some drowsiness and anticholinergic side effects. We must avoid using this drug in elderly age group, because urinary retention, especially those who are having prostatic problems, so the patient might land up in urinary retention. Insulin plus dextrose is a wonderful drug for starvation ketosis. The main side effect is hypokalemia. So many of the patients who are coming after a prolonged fasting, like Jain people after that their holy month, like Muslim people after the Ramzan month, for Hindus after the Navratris. So for any of these patients who are coming after prolonged fasting for more than 5 days, 10 days, for these patients, always check for the serum and urine acetone. If it is present, then the patient is having starvation ketosis. The typical history is that they are not able to eat anything. As soon as they are eating, immediately they puke it out. Also, if you give any oral tablets, it will not work very well. Even if you give MSET, Perinom, so it will not work very well. So you need to hydrate these patients well, plus you need to clear their ketones. So what I do in my clinical practice, if there is a ketone positive for such patients, I give a 5% dextrose with around 6 units of insulin, and around 40 milliequivalents of potassium. So again a quiz question. So in many patients we find that there is hypokalemia in vomiting. So from where does the potassium comes? So around 1 liter of gastric juice will have 20 milliequivalents of loss of potassium. So this is not a predominant cause of loss of potassium, because 1 liter of vomiting is a huge amount of vomiting. Basically what happens, the patient will develop metabolic alkalosis, and because of metabolic alkalosis the patient will start losing potassium from the kidneys. The patient can lose up to 40 to 60 milliequivalents of potassium from the renal route. So the total deficit in a patient of acute vomiting with metabolic problems, either acidosis or alkalosis, the patient will lose around 60 to 80 milliequivalents, and we need to replace this potassium. So if you give insulin in the case of hypokalemia, it can cause major problems. Centrally acting drugs like haloperidol and lorazepam, it is important for cannabis hyperemesis syndrome or patients of psychotic vomiting. A main side effect is drowsiness. And rizatriptan or sumatriptan, in the dose of rizatriptan around 10 milligrams and sumatriptan 50 to 100 milligrams, they act on 5-HT1B and 1D receptors. So they are helpful to abort vomiting episodes in migrainous, status migrainous, as well as cyclical vomiting syndrome. The main side effects are heartburn and chest discomfort with dryness of mouth. So that's all for now. So we have discussed how to investigate a patient of vomiting and the common drugs that we use with the indications. So stay tuned for the next videos. In next videos, we'll discuss few live interesting cases that I have come across in my life. Thank you.
गैस्ट्रो गुरु के साथ बढ़ाएं अपने पाचन स्वास्थ्य का अनुभव, जहां विज्ञान और वास्तविक ज्ञान मिलते हैं। ऑथेंटिक मेडिकल हेल्थ इंफॉर्मेशन, गैस्ट्रो गुरु के संग।